Well, greetings, students. Today, I'd like to talk to you about the biopharmaceutics and ADME properties of therapeutic proteins. So, as far as our learning objectives go, what we're principally interested in doing here is comparing the therapeutic protein drugs to small molecules small molecules that you're used to, like lisinopril or simvastatin, in terms of their ADME properties. And these learning objectives really are taken directly from the book Clinical Pharmacokinetics, which is available through the Access Pharmacy and referenced on the last slide of this set. As far as terminology goes, let's kind of try to get that straight to the extent that's possible. Unfortunately, the therapeutic protein drugs, which are also known as biotech drugs, really are not a group that's that well defined, but they're quite different from the small molecular weight drugs that are, say, under 500, the ones that you're used to. Most of the biotech drugs contain multiple amino acids linked by peptide bonds, and you should know what a peptide bond is by this point. And it's somewhat arbitrary, but peptides with larger molecular weights over roughly 5,000 can be considered to be proteins. Smaller ones like insulin are generally considered to be peptides. Antibodies are good examples of proteins at the upper end of the molecular weight range and can have well over 1,000 amino acids in them. Okay, so again, therapeutic proteins, biotech, kind of synonymous. There is one exception I know of, and that is the class of drugs that Dr. Marsing talked about. Hopefully that you guys can kind of know what those are. Okay. And those were the antisense drugs, which are nucleic acid based. Now, before we even talk about these drugs, we have to make sure that we're clear on what they're composed of. And although they're proteins, there can be variations in the actual amino acid composition of these compounds, and then they can have other parts. They can have sugar molecules attached and other components that Dr. Marsing mentioned through post-translational modification. In any event, many of the drugs that we're going to be talking about, therapeutic protein drugs, one batch is not molecule for molecule, atom for atom equivalent to another batch. Okay, and that can really cause some challenges in terms of characterization of these compounds. So in terms of even just molecular weight, we really can't always give an exact number. It's oftentimes a range. And analysis of these compounds can really be difficult as well. So what's often done is an immunoassay approach is used, such as an ELISA, enzyme-linked immunoassay, which looks at just a kind of a piece, a portion of the protein to quantify or characterize it. But we just need to keep in mind that what is actually being measured is a little bit difficult to get a handle on, always of a concern. Let's start with absorption, the movement of drug molecules from the site of application to the general systemic circulation. Okay. Well, therapeutic proteins, because of their instability in the stomach and their resistance to being absorbed through the intestine, are almost always administered parenterally, something other than enteral, meaning something other than a GI route. And that can include intravenous, subcutaneous, or IM. Now, these sites of absorption can cause difficulties in the sense that absorption is often slow and limited. Okay, and I just want to point it out because it's not intuitively obvious that just putting the drug under the skin, say with the subcutaneous, really does not make it, does not contribute, in and of itself is not absorption. Okay, it's not absorption because even though it might be technically in the body, it's not part of the systemic circulation, and that's our frame of reference for absorption. And this is just showing molecular weights of some compounds, and it's a little confusing, kilogram per mole, but this is kilodaltons, or molecular weight times divided by 1,000. So, for example, insulin is 5,600 molecular weight. And then you can see for a number of things, there's a range. There's a range because, as we said, it's not just one precise, well-characterized molecule. You see bioavailability, and these numbers are fractions of 1, so multiply them by 100 if you want percent. So bioavailability of insulin, 84%. Bioavailability of TNF-alpha, roughly 10%. So you can have very low bioavailabilities. And time to peak concentration after these parenteral routes can be quite delayed relative to, say, an oral dose. And I do want to point out the problem with bioavailability. Everybody thinks, well, you have to give it a lot more drug for a low bioavailable compound. That's true, and that is a little bit of a concern. But cost of goods is generally not the major issue with drugs. The problem is variability. If you have something that has a very low bioavailability, say 0.1, there's going to be a huge range between individuals. It might actually be 0.5 to 0.3, which is like a 6-fold difference in exposure. All right, and this is just showing you more of the same thing here, how bioavailability can be low for monoclonal antibodies. The other thing I do want to point out here, which is the elimination half-life for these antibodies can be fairly long, which is unusual for a protein therapeutic drugs as a class. And we're going to talk a little bit about why that is later. So let's move on to absorption, our first letter of our ADME paradigm. Well, there are these two kind of basic mechanisms that most of these protein drugs can reach the systemic circulation: diffusion through blood capillaries and convective flow into the lymph vessels. Okay, I'm going to show you a diagram of that in a minute. The other thing I just want you to keep in mind that first pass loss can often be extensive because the compounds break down where they're administered. And let me just take a minute to tell you that what I mean by first pass loss is the loss of the drug when it first enters the systemic circulation. Okay, so first pass in this context is because the drug can break down where it's deposited. Okay, that's different than first pass after an oral dose where the drug is breaking down before it hits the systemic circulation through an interaction with the liver. Okay, so just kind of keep that in mind. These are both terms, first pass, but they're totally different mechanisms for small molecules and large molecules, protein therapeutics. Okay, so going back to those two different mechanisms of absorption, if we have a drug that's administered IM or SC, we can see that it kind of just begins to permeate and dissolve in the interstitial fluid. All right, or if it's in a liquid, it just will diffuse into an interstitial fluid. And then, depending on its molecular weight, if it's a fairly low molecular weight, we're going to see roughly lower than 30,000. It can get through blood capillary into the plasma in a more or less direct way. If it has a high molecular weight, and arbitrarily greater than 30,000, it will go into lymph, this separate circulatory system that we have, which is called the lymphatics, and it goes into lymph vessels, and then from there it can get deposited into plasma, kind of an unusual pathway. So Again, as I mentioned, the therapeutic proteins that have molecular weight of roughly less than 30,000 can travel from the site of administration across blood capillaries into the systemic circulation, where those that have a higher than 30,000 molecular weight essentially get moved into the lymphatic system and from there dumped into the blood. Now, I do want to mention that the molecular weight cutoffs I'm talking about may vary a little bit from what's in a book, and that is because I'm just trying to keep things simple through the discussion here and stick with just a couple of cutoffs. And these cutoffs are all somewhat arbitrary anyway. They're not just one number. And here's kind of an example of that. You see that the molecular weight, okay, the molecular weight here versus the capillary permeability, it just doesn't just drop off all of a sudden. There's no one number that characterizes yes or no. It's kind of a almost continuously variable situation. But this group of very high molecular weight protein therapeutics like antibodies really essentially don't get across the capillary permeability. The capillaries, they're absorbed by the lymphatics if they're administered subcutaneous or IM, whereas the lower molecular weight compounds can get into the systemic circulation by traveling into the blood vessels through the capillaries. And this is just for your information, really, to go back and see if you can kind of refresh your memory in terms of the lymphatic system. The main thing to remember is that lymph flow is very slow. It's maybe 100th or 1,000th the rate of blood flow. There is no, lymphatic pump like a heart. It just travels slowly through the movement we make, kind of slowly pumping the lymph through the lymph vessels. But at the end of the day, the interesting thing is that this lymph fluid, which is collecting the therapeutic proteins, ends up dumping into the systemic circulation through these lymphatic ducts. Okay, so the lymph collects the therapeutic drugs in the case of a high molecular weight compound and then returns it to the blood, so it ends up in the systemic circulation. Therefore, it is quote unquote absorbed. Okay, and this diagram is just again showing you the relationship between molecular weight and then the amount of the drug that can be recovered in the lymph. So just to go over a few of the factors that determine the rate and extent of absorption, keep in mind that lymph flow is slow and causes a delay in absorption. And these non-vascular routes can that absorption of the therapeutic proteins really typically involves is very variable, leading to big differences in bioavailability. Degradation can occur at the site of drug administration. Okay. And then the other thing that I want to point out is that the subcutaneous and IM route here have an advantage, if you will, of providing prolonged input for short half-life proteins. They can actually act like kind of a depot or a delayed release. So what we get is what's called absorption rate limited pharmacokinetics. Okay, let me give you an illustration here. Here's serum growth hormone. You can see that when the drug is administered intravenously, blood levels come down very quickly, very short half-life. Now that is the real half-life. That's the intrinsic half-life of the drug. Okay. Now, when it's administered subcutaneously, we see we have sustained blood levels, and we have what appears to be, or I should say, an apparent long half-life. Okay. It's only apparent because the half-life is really determined here by the rate of absorption from the site of administration. Okay. So just keep that in mind, that the actual half-life of the drug itself is not changed. It's the apparent half-life is changed because you're really looking at the absorption rate, not the elimination rate. So there are a number of factors that influence absorption. I just want to quickly go over these. Body weight, gender, age, activity level. It's really, if a person is moving around a lot, it can alter the flow of blood and lymph and interstitial fluid to the site of administration. Maximum injection volumes, pre-systemic degradation, blood flow, many things. Let me continue. And then, of course, we have the drug substance itself, the size, polarity, charge, specific interactions with receptors. The formulation of the drug makes a difference. And, of course, the injection site, whether or not you rub the site of injection, and then how long the injection occurs. So you can see that, again, I just want you to always be thinking in terms of small molecules. There are a number of factors which can lead to variations in the rate and extent of absorption of these drugs. So for a typical oral dose, what do you have? You have transit time, maybe, and you have food interactions. That's about it. Here, there are a lot of factors. I do want to point out that on the bottom here that most antibodies are administered by short-term IV infusion. They're really, the absorption by SC or IM is just so poor that they're administered by IV infusion. And as I mentioned earlier, which we'll return to, they have fairly decent half-life, so you can do it that way. So I mentioned that site of injection makes a difference in terms of absorption. Here you can see that administering growth hormone in the thigh versus the abdomen has almost a twofold difference in bioavailability. And the best way to deal with this is to have a patient find a place that's relatively convenient as a site to inject the drug and stick with that, so that once they know that they're getting therapeutic levels by injecting at that site, they stick with that site of administration to minimize variability. And this is just showing what we've already talked about, the subcutaneous versus IV dosing of a therapeutic protein like erythropoietin. You can see that the AUC, when we give it subcutaneously, is considerably lower than the IV. That's really, by definition, the bioavailability, maybe about 35% or so. Maximum concentration is lower, and the half-life is considerably longer after the subcutaneous administration. This is a little tricky. See, they're calling it terminal half-life. It really should be apparent half-life. Okay, let's move on to the next letter here, D, reversible transfer distribution, the reversible transfer of drug from one location to another in the body. And keep in mind that the characteristics of these drugs is essentially they're high molecular weight hydrophilic molecules. Okay, and because of that, they have difficulty entering cells of the body, and they're restricted pretty much to the extracellular space. Okay, so these drugs, when administered, are generally have volumes of distribution which are just a small fraction of the total body water. So typical total body water is maybe 0.7 liters per kilogram. You can see that that they occupy only a small fraction of that space because they don't get into cells very well. Now, the other thing that affects distribution is binding to endogenous proteins. So when we talk about small molecular weight drugs, we're talking about albumin binding, right? Reversible albumin binding. Well, some of these endogenous protein therapeutic drugs have carriers themselves, like growth hormone, for example, has its own carrier. And those carrier proteins act to increase the stability of the drug, that is, reduce its clearance and reduce its volume of distribution even lower. So as I say here, it's very much like small molecules interacting with albumin. And I know you've hopefully remember this from PDA1, but we have different kind of capillaries. We have those that have continuous junctions between epithelial cells and those that have discontinuous. And hopefully you can remember that brain and testes have the continuous junctions. So protein therapeutic drugs really have a difficult time. Essentially, don't really penetrate at all into organs that have those continuous epithelial cells, such as brain. And this is a table. This table is just illustrating the fairly low volume of distribution. You can see it's a fraction of total body water for most of these protein therapeutic drugs. This is a interesting experiment that was done where they looked at growth hormone and the effect of it binding to its endogenous receptor. Now, you can't really do this experiment in a human being because they have I didn't mean it, not the receptor, but the carrier protein. So you can't really do this in humans because humans have the carrier protein all the time. But in a rat, you can administer the growth hormone with and without the carrier protein for it. And you can see that when you administer growth hormone complex with its carrier, the clearance is much lower when it's just the growth hormone alone, and the volume of distribution is much lower than when it's the growth hormone alone. Now, moving on to the E part of our considerations, elimination. We're going to be talking about the irreversible removal of drug from the body by excretion and or metabolism. So let's keep in mind what metabolism is. Metabolism is a change in the structure of the molecule. Okay? All right. Now, we know that protein therapeutic drugs are usually very hydrophilic, okay, water soluble. So when they reach the liver, what happens? Nothing. The P450 enzymes of the liver really don't do much because they just don't bind the drugs. Nevertheless, so the role of the liver is generally minimal, okay? Nevertheless, and here's the odd part, these protein therapeutic drugs are eliminated primarily by metabolism. In other words, they are chewed up, if you will, by the body. Now, hopefully you can remember that they're peptides and be able to make a pretty reasonable prediction what happens to peptides. And remember that magic word that they're hydrolyzed, okay? Where does that happen? Well, it's kind of strange. It happens in the kidney, okay? Protein therapeutics that have a lower molecular weight, again, we're using the cutoff at 30,000, okay, are filtered at the glomerulus, right? They go into the renal, the tubular filtrate. Now, this is different. Catch this. They're taken up, okay, they're endocytosed by cells of the proximal tubule, and there they're hydrolyzed, okay? They're hydrolyzed. That's the way they're metabolized, all right? So that's for the relatively smaller protein therapeutics. The high molecular weight protein therapeutic drugs, like antibodies, go to the glomerulus and they're not filtered. Just like albumin is not filtered. They bypass the kidney and they're metabolized elsewhere. Okay? So generally speaking, protein therapeutics are eliminated by metabolism, and smaller ones are metabolized in the kidney. Okay, and higher molecular weight are metabolized elsewhere. We'll touch on what elsewhere means in a minute. Okay, so I have my question: what happens to amino acids that are released by hydrolysis? Okay, hopefully you'll be able to keep in mind that we don't throw away amino acids. So what does the body do to those amino acids? Is P450 involved in this overall in the elimination in the kidney? Hopefully you can answer that. And then based on that answer, are metabolism-based DDIs an issue for these compounds? I'm going to leave that up to you to answer those questions. So it's just a diagram kind of showing you that that when you have a protein drug or any drug, it can go through the kidney. It can be, if it's lower than 30,000 molecular weight, it's filtered. If it's not, it just keeps going. And those that are filtered can be taken up. These are proteins now. They're endocytosed into the tubular epithelial cells, where there are these little subcellular organelles called lysosomes that have a fairly extreme pH that can hydrolyze the proteins. This diagram is just showing you and this is important to understand, that for those therapeutic proteins that are filtered, the ones that have a lower than roughly 30,000 molecular weight cutoff, such as this one here, anakinra, the rate of clearance by the kidney is proportional to the rate of creatinine clearance, or just the glomerular filtration rate. Okay. Now, even though, just keep in mind that even though there's virtually no unchanged drug found in urine, the kidney is the principal organ of elimination, and that is because the kidney is functioning as a metabolic organ in this case. Very unusual. We don't see that with small molecules, so that's a real distinction between protein therapeutic and small molecules. Antibodies are a little bit different. They're not filtered at the glomerulus, and their elimination is kind of complicated, really. First of all, it's much slower. That's why antibodies have a fairly long half-life, and occurs by this so-called fluid phase endocytosis in the cells throughout the body. So cells throughout the body endocytose, they very slowly take up antibodies, and there the lysosomes in these cells can break it down. But many cells, because there's an interaction of antibodies, the common portion with cell receptors that are there and recognize antibodies in general, there's a kind of a recycling, because we don't want to break down our own antibodies too quickly. So even though many of these antibodies are taken up, they're recycled. So this is an interaction with a receptor. And one thing you can always remember, whenever you have any interaction with receptors, you're going to have saturation. So clearance rates are low and not dependent on renal function. I hope that makes sense. And because you have this saturable binding, because you have interaction with the cell surface receptors, you can get saturable elimination. And this diagram is just showing that the elimination rate for the monoclonal antibody efzofitimod is a function of dose. So you're at very low doses, you have fast elimination rates. At higher doses, you have slower elimination rates. And this would be, say, after an IV dose, so we don't have a complication of absorption here. This is purely the elimination. I did want to just touch on therapeutic protein derivatives. We have three different types that generally are a part of the manufacturing process for these. One is pegylation, the other glycosylation, the other is albumin infusion. And what these are ways to basically extend the half-life of these drugs by adding something to the therapeutic protein. covalently. Okay, so pegylation involves adding polyethylene glycol, glycosylation, adding sugar molecules, albumin fusion, adding albumin to the therapeutic proteins. And just kind of keep in mind this is covalent. This isn't something that dissociates in solution, right? So what happens, we'll just look at this one, the protein with the albumin in this case. Let's see. Yeah, pegylated protein. Basically, what's happening is that you've extended the size of the molecule and the hydrophilicity. Okay, what does that do? Increases water solubility, decreases glomerular filtration rate. Remember, we talked about that just in the past couple of slides. And it also decreases immunogenicity. The immune system has a harder time recognizing or attacking the protein when it's got all these extra molecular portions attached to it. All right, I think that's about it for that lesson. I know it was quick and brief, but this reference from Rowland and Tozer, Pharmacokinetics, is just super, very easy to read and understand. Maybe half dozen pages or so, dozen pages maybe. I would highly encourage you to read that over so that you get a more thorough understanding of these drugs, because these drugs are the protein therapeutics are getting to be a greater and greater percentage of your therapeutic armamentarium as you move forward. It's really important that you understand them. And the disposition is, in many cases, quite distinct from that of small drugs. All right, so that's it for now. God bless and take care.